Good afternoon and good evening, and thank you for joining us for the weekly briefing from Africa CDC. My name is Margaret Edwin, the Director of Communications. I will be moderating this session. The weekly briefing touches on health emergencies across the continent, and today we are joined by Professor Yap Boom, the Deputy Incident Manager from the Incident Management Support Team based out of DRC. I will now hand over the floor to Professor Yap to start the session. Over to you, Prof.
Good afternoon, Director Margaret. Good morning, good afternoon, good evening, of course, depending on where you are. So I'm pleased to take the press briefing on behalf of our Director General, Dr. John Kaseya. And then happy to have the presentation now. So as you recall, 2 weeks ago, we were all gathering 20,000 African scientists, leaders, and so on in Durban during the safe year. And we came out with the Durban Promise, if you remember well. And the idea of that promise was that it could feed the G20. So today, the ministerial meeting is going on, and there is a critical session which is dedicated on the peril of financialization. And at the same time, our Director General, Dr. Jean Kaseya, is actually delivering his remarks together with all the different Ministry of Health. So that's the reason why he's not with us today. So he's sending his apologies, but you understand that this is also a critical moment for the continent that he's going to handle. So we also had in Pretoria this very important gathering between the African Union and the European Union, really to look at the different corners of the health partnership framework. And one of the key pillars of this discussion is how we do move on the Africa vaccine manufacturing agenda by building a sustainable, competitive ecosystem where our vaccines are produced, procured, and provided on the continent. If you recall, 98% of the vaccines that are used in our continent are imported. And then we have been having different opportunities from COVID with the mRNA vaccine, with MPOX, with Bavarian Nordic, try to really push that technology transfer and production in the continent, knowing that there are opportunities, different sites in Senegal, in Morocco, in Algeria, and South Africa, sites that are ready for that. So the idea of this gathering and to emphasize is that we need to walk the talk to ensure that we keep on moving until we can see this happening. And this is a way for the continent to reaffirm the health sovereignty, to emphasize that no, it's not a dream, but it's really a necessity for the continent, not only our future, but really our present. Next slide. Around the different leaders that was meeting with the World Bank Group, which is the institution where we are really talking about financing, funding, and do all those innovation. We have different health workers leaders that was all together at the roundtable. We're having Dr. Jean Kaseya. We are also having Dr. Tedros, the Director General of the WHO. So in this dialogue, it was clear to reaffirm the shared commitment to invest in stronger, more resilient health system everywhere. And the key word here is to invest, because we believe that health is not a charity, but really an investment. And at the core of the message, it's strong health systems save lives, because they are the foundation of preparedness, effective response, and also health sovereignty. We come back to that because we really want the country to own the health and to have the means to actually making sustainable, equitable for all the different communities. Next slide. Dr. Kaseya also attended that important moment where the focus was around more money for value and more value for money. More money means that the three pillars that we've been pushing for in our Green Book on the increased domestic funding, the innovative and blend finance to support programs that deliver better health outcomes. So the message remained the same, so that by increasing this mass of funding, we are able to respond to outbreaks, but also to provide universal health coverage. And this with more value, being more efficient. How can we do better with less? And that goes with improved governance to align with external funds and also use the pool procurement to cut the fraud and the wastage. We mentioned that last week, how this procurement was come to support countries like Namibia, Botswana, but many others having a more powerful organ that can really support and which will help free between 10 to 25% of the budget for primary healthcare. Next slide. Now, this is an article that was published this week on cholera. Though we'll come back to the epidemiology, it's important to highlight that the continent, the entire Africa, have not seen such an important outbreak of cholera for the last 5 to 10 years. Looking at the number of cases, looking at the number of deaths, as I will come later on, this is really the first time. So in this article, we underscore that yes, cholera remain a major but preventer killers because the solution, we know them. We know the wash, we know the vaccine, we know the community engagement, but still we see that more than 6,000 people have died just this year between January and October because of cholera. So in the plan that was launched in August last year, it's important to emphasize the key innovation really to bring the cholera at the political level with the engagement of the head of state, with the AU champion for cholera, the president of Zambia, to ensure that we have a continental task force that is led by the AU champion, but then pushing, supporting the peer president to have in each country the presidential task force, so that cholera move from the level of the Ministry of Health to the level of the presidents. That will then allow to have a sustainable, country-owned and accountable response to cholera. Because then we'll have the Ministry of Health, definitely, but we will also have the Ministry of Planification, the Ministry of Finance, the Ministry in charge of water and infrastructure, and the Ministry of Local Government, because the decentralization is happening in many of our countries. But also to highlight that we need support. We need to mobilize domestic funding, as just mentioned before, but also support from different partners to raise the 231.7 million that will allow us to get the oral cholera vaccine, but also the treatment center, the rehydration point, and the provision of oral rehydration sachets that are critical to support the patient. And of course, the 400,000 liters of IV fluid that may be needed for those who are in a severe case. So this has been published in Nature Medicine, emphasizing the need as a tool in terms of advocacy, but also showing the path where we want to work together with the political, the strategic, and the operational level. Next slide. Now, going back strictly to our epidemiology and the public health event, we still have MPOX that is leading in the number of confirmed cases, the 39,334 since the beginning of the year, with 908 deaths. Cholera in the 23 member states that I will show later. Measles, which is still an important challenge, though we don't speak here about it often, is still causing the life of 1,141 of our population this year. Dengue, with 11 member states, will come to dengue in Sudan, that I will emphasize in this presentation, and also Lassa fever that we've been highlighting, which is affecting 4 of our member states, but which has already caused 188 deaths in 2025. Next slide. Ebola in DRC, we keep on counting down. We are 27 days to the declaration of the end of outbreaks. The vaccination has been continuing. We have a total of 37,178 people that have been vaccinated. While we are moving toward the declaration of the end of the outbreak, we are also supporting the surveillance, because we've learned from the past. We've learned from those experiences where at day 40, 2 days before the end of the declaration, we have some new case. That's happened in DRC. It also happened sometime in Guinea. So it's important to remain vigilant on one side, but also in the other side to really take advantage to strengthen the health system. So our colleagues in the field will keep on working to strengthen the surveillance, especially the digitalization. We've been supporting with the use of the DHIS2 tracker to ensure that we have real-time data, but also the use of Starlink to ensure that we have data that remote in a very real-time manner. Next slide. The Rift Valley fever is carry on in Senegal, but also in Mauritania. Mauritania, it's a bit mild as we do speak now, but in Senegal, we still see the number of cases that are increasing. We moved from 54 to 60 cases this week. The number of deaths has decreased from 6 to 3, but these are still 3 people who passed away because of the Rift Valley fever. And as we know and we've been mentioning, it's a zoonosis also affecting the animal more on the side of the abortion that has been reported, which definitely have an economic impact on the affected population. The case fatality rate is quite high, 7.4%. Just as to compare, MPOX is around 1%, cholera that we'll see is around 3%. In Senegal, we have 29 deaths out of the 391 confirmed cases. So it's a big challenge. And then the colleagues from WHO, from Africa CDC and others are really supporting the government of Senegal because to ensure that we support them in controlling the spread. As you can see on the map, you have more and more districts that are affected. So it's critical to support as much as possible to limit the spread of the Rift Valley fever in Senegal and in Mauritania. Next slide. The dengue fever in Sudan, due to the flooding that carry on, that have been reported sporadically since July 2025, we are seeing these dengue that has been increasing. Now we've already reached 200 and 141 cases this week, though a reduction of 47%. Number of deaths, we have 9 deaths this week, so that's make a case fatality ratio of 0.29, which has increased actually as compared to what we had in 2024. So you can really see how this has increased, and this is between the climate change with those flooding, but also Sudan is a fragile health system, which is also weakened by the civil crisis, which make more difficult to access the population, but also to have a proper environment. And if you don't have that environment, it's there, the environment where the different mosquito can actually have their eggs and then produce themselves. And the concurrent outbreaks that we've seen in Sudan, we will come back to that. With cholera, they've been also having MPOX. So managing all those outbreaks at the same time is a huge challenge, especially when the country is affected by the civil crisis. Just to highlight once again that there is no health without peace. Next slide. Going to MPOX, we can see that the situation is quite stable with the number of suspected cases at 1,869, the number of confirmed cases 322, as compared to 311 last week. What we keep on seeing is definitely the decline, more than 80% if we consider the last 6 weeks to the peak, 80% the decrease, but also in the confirmed case. And then Namibia, as we keep on following, as we mentioned, we were supposed to have the Minister of Namibia today, but as mentioned, they are all attending the G20. They are still having 2 cases, as we'll see in the next slide. Next slide. So when we look at the evolution of MPOX in different countries, we can see that in Central African Republic, that is a country that is endemic for MPOX, we now see some new districts that have never had MPOX that are seeing some new case. And when we compare the week, we were having 13 cases confirmed in the week 32 to 37, and this last week we had 23 positive case. Though it might appear small in numbers, this is a place where we are dealing with the clade 1A, and you can see that the number of deaths, it's 4, while most of the other countries are lower than 2 digits, despite a more important number. So that's a very concern, and we know that currently the country is pushing for the vaccination in this new area. Now, in the other countries, Kenya, Liberia, Ghana, we can really see that the cases are still increasing, and an important number, you can see, for example, Kenya, where we had 261 cases over the last 6 weeks, Liberia 440. So this morning we engaged the Director General of the NIPH to better understand the situation, and I will come to that in the next slide. On the other side, we have other countries where we keep on seeing the decline in the number of cases, which is important, and we are gladly see the decrease in DRC, though you can see that it's still providing the highest number of cases as we look at the entire country of the continent. Next slide. Going to Namibia, where we went last week, we still have those 2 cases that are admitted, and hopefully they will be discharged by next week, because one of the cases has resolved all the lesions. Another one still have some few. So we are monitoring on the side of the clinical, but also on strengthening the surveillance in the country with the response plan that they are putting in place, which will really support the active surveillance in the different provinces that have been affected, but on one side, but also the laboratory decentralization. All that on a very strong leadership from the Ministry of Health. Next slide. In Liberia, we had a very important discussion every Thursday in the morning, like we have this discussion in the afternoon with you. We have a discussion with the different member states to present the situation. So today, Liberia was highlighting the challenge that they are facing on the side of active surveillance. As you can see, the test positivity rate, which is the proportion of patients that are positive among those tests, you see it's around 65%. We expect it to be around 30%, showing that we are actually capturing the positive patient in the community. The higher it is, it means that we are capturing patients at the level of the health facility, which is too late. So this emphasized the weakness in the active surveillance, which we agree there is a need to support in epidemiology, but also on the community healthcare workers being present in the community. The other challenge that they've highlighted today is the management of patients. So they are implemented the home-based care because they believe that what works better for them, considering the constraint on availability of health facility. So now the challenge is how to strengthen that home-based care so that we can really isolate patients at home, not just letting them at home, but isolate them. So that's one of the support that they need, and they will be provided. The last one is on the vaccination, to ensure that they vaccinate the right population. They've already vaccinated 7,841 people that have been vaccinated, while they received 20,000. So there's a possibility for them having more vaccine, but that will depend on how the epidemiology is moving, but also the challenge that we have on the availability of operational cost, the money that is needed to move the vaccine from the stock to the arm of the population. Montserrat County alone counts for 69.2% of all confirmed cases. So this is really the place where all the active surveillance has to happen and will happen in the coming days. Next slide. In Kenya, we see a slight decrease in the number of cases between last week and this week, which is important to highlight. The vaccination has been done with 10,000 people vaccinated. Now the new allocation is still pending. The country is finding how they can absorb the vaccine, because this vaccine comes without operational cost. So it's important for the country to see how they can mobilize domestic resource and being able to provide those vaccines. Now, when we look on the side of the surveillance, a lot of progress has been made with a testing coverage of 100%, similar to the testing rate, and the test positivity rate around 36% mean that they are actually going to look for the case in the community. However, when we look at the contact list that we have, less than one contact for one case, while we were expecting to have 20. This is also a point that where the IMST will be supporting the Kenya in the coming days. Next slide. In Ghana, we've seen a surge in case. While we were seeing that decrease to 9 cases last week, we go back to 51, which is what we were having before, still due to that clade 2B. So we can also see an improvement in the community surveillance that has led to that increase, because you can see the test positivity rate has moved from 11 to 33%, while other indicators remain good. The 72% of confirmed cases were concentrated in the Greater Accra and the West End, which highlight that the strategy today is really, as we've seen in Sierra Leone, to go in that hotspot, ensure that the active surveillance is happening, the isolation of the positive is also happening, and also the place where the vaccination is happening. As you can see, 85% of the target population have been vaccinated. And then we hope that in the coming days of week, actually, we'll be able to see the impact of that vaccination. Next slide. Now, on the vaccination, as we illustrate and mentioned last week, we are happy to celebrate partnership. You know, when you are responding to those outbreaks, it's really a war. It's really a battle. So when we have some positive outcome like this partnership with Bavarian Nordic that has donated 110,000 additional doses of MPOX vaccine that will all go to Uganda. I think they must have reached Uganda. It's important to acknowledge and to celebrate those partnerships, because that really strengthened the ongoing outbreak response in a country that has already used more than 150,000 doses of vaccine. Now they will have those extra. And remember that Uganda is one of the countries that is really making advocacy to increase the herd immunity against the MPOX. So we believe that this will be really catalytic to allow the country to reach towards that objective. Next slide. Now, what we see at the continental level, just to remind that we are currently using two vaccines. We have the MVABN and we have the LC16. The LC16, it's only in DRC, which is supported by the government of Japan that has donated 3 million doses of vaccine to DRC, while we have managed to raise 1.83 million doses of MVABN. So as you can see on the graph, 77% of countries with MPOX vaccine have actually utilized above 50% of their stock, reinforcing the call for more vaccine, operational funding, but also highlighting that there is no vaccine hesitancy as we are seeing what is happening in the countries. Now, on the side of specifically for the MVABN vaccine, as we do speak now, 1,018,000 doses have been administered, 1.1 million people have been vaccinated, and for the LC16, we have 500,000 of people in DRC, in the Sankuru, Kinshasa, and North Kivu that have received that vaccine. That is really impressive, knowing the logistical challenge of absorbing that specific vaccine. Next slide. From MPOX, we move to cholera. And remember that I mentioned this is surely the more important outbreak of cholera that the continent have seen in the last few years. You can see we keep on counting every week how we see the number of total cases that are tripling what we've seen in 2022. And same thing for the number of deaths. We are at 6,927 deaths. But what is also important is that as compared to last year, the case fatality ratio has increased. From 1.9, we now have 2.3% of case fatality ratio. And now we have 3 new members that has been affected. And this is happening. We are just starting the month of November. If you were here in Kinshasa, you were seeing all the rain that are happening currently. In Sudan, we've been talking about flooding. All those drivers that are critical to carry on to scale the spread of cholera in the continent. So we are not yet there. And if nothing is being done before the end of the year, you will keep on seeing the number increasing. Next slide. So now when we go back, we look at all the different countries as together, we can see that Angola and Burundi are really the one leading in terms of the percentage of change. Specifically, Angola was with almost 700% increase, moving from 600 cases in 6 weeks to 5,600 in the last 6 weeks. This is definitely one of the most important increase, followed by Burundi. But what is also important to look is some countries like DRC, like Sudan, though we can see a decrease, they are still contributing the highest number of cases, 7,000, almost 8,000 number of cases in DRC for the last 6 weeks, almost 4,000 in Sudan. That is still a lot of cases, which means that a lot of work still need to happen. Next slide. Specifically for Sudan, happily, we can see the decrease on the number of cases. The case fatality ratio still remain high with 2.7%. And remember, we are talking about Sudan. This is the same country affected by the crisis. This is the same country where we've highlighted the outbreak of dengue. And of course, you know the challenge that happened in El Fasher in the country. So really the country is affected by all those different outbreaks, which make difficult the support and the access to patients. But however, gladly, we can see this decrease, and then we hope that it will be sustained despite the rainy season that is about to arrive. Next slide. In Burundi as well, we can see the continued increase in the number of cases, though it's a bit stable. What is interesting and important to highlight in Burundi is that the case fatality ratio remains pretty low. With 10 days, it's 0.4%, while most of the country will be around 2 and beyond. This is a trademark that we've seen in Burundi even since the MPOX outbreak, where the country has reported 1 death for the entire time that they were having the MPOX outbreak. So this is important also to highlight and to learn from Burundi on the capacity to manage the patient despite the increasing number of cases, because you can see that they've already reached 2,247 cases while they have 10 deaths. Next slide. Angola, it's now the country that is reminding us that medical solutions don't stop an outbreak of cholera in a sustainable manners. As you can see here, we have that significant first wave where a lot of effort has been put in place on the IPC side, the WASH, the vaccination as well, and then we were gladly seeing that decrease. Until now, we see this new wave, second wave, where we currently have, for this week, we have 768 cases, reduced from the 1,043 that we had last week. The number of deaths has increased from 7 to 9. And the hotspots are the same, persistent. We have Ula, Urge, Kunene, and Lunda Norte, notably Kapenda, Kumulemba in Luanda. So the OCV coverage, cumulative OCV coverage exceeded 3.57 million people. Despite that, you can see that we had all those, that new wave with all those cases. This is a reminder, if needed, that the watch has to be implemented, but implemented well in the sense that the population need to have access to water, but really access to clean water, because in some place you can have access to water through the tap, but this water may not be of a good quality, and therefore continue to spread the cholera in many countries. Next slide, sorry. In DRC, as mentioned, despite the decrease that we are seeing, you can see that the situation is pretty stable. Case fatality rate very high, 3%, 1,815 deaths, more than 60,000 cases. You can see that DRC remain really one of the top countries as cholera is concerned. The OCV coverage is around 90% in the 7 target of Kinshasa, Zone de Santé. And then the hotspots are Rutshuru, Binza, Mwezo, Bilambizo, and Kibirizi. So now, when we look at specifically the mortality or the case fatality ratio, you see that the provinces of Equator, Sankuru, Tanganyika are really the top three. So that's why the conversation that is currently happening is how we can strengthen the surveillance, the WASH in these provinces, especially Sankuru, where we have few humanitarian actors, but where the case fatality ratio is high, as well as the number of cases. 20 provinces has reported at least one case, and the South Kivu alone counts for 17% of all the cases. In total, 222 health zones have documented at least one case. Next slide. In summary, we are in the countdown for Ebola, 27 days to go toward the declaration of the end of the outbreak, but vigilance remains, but also the opportunity to keep on strengthening the health system in the Boulapé zone de santé. The Rift Valley fever is also continuing to spread in Senegal with the decrease in the number of deaths. Dengue is affecting Sudan, which is also affected by cholera. So highlighting that it's very hard for a country to deal with the climate change, at the same time, the humanitarian crisis and having those different outbreaks. So there's a country that really needs significant support at different level, operational, strategic, political level, so that we can provide a comprehensive solution to the situation in Sudan. So MPOX, we can see that the transmission continued to increase in Kenya, Liberia, and Ghana, which remain really the major concern, and where the major support from the IMST and partners will happen in the next few days, so that at the end of this month, we hope to see a decrease, and our ECG will be sitting in the early December to reassess the situation of MPOX as effects in the continent. Cholera, just to re-highlight, and this is an important advocacy, it's really one of the worst outbreaks in the last few years in the continent when we look at the number of cases, number of deaths, especially in DRC, Sudan, and now Burundi, and of course, Angola, which is experiencing a second wave just before we are seeing the rainy season, which is of concern. But we believe that together, with a strong plan, with all the partners that we are putting all together at this time, we'll be able to see the decrease of cholera moving toward its elimination by 2030. So I will stop there, and I will be happy, Director Margaret, to take some questions for our dear journalist.
Thank you very much, Prof. Let's take the first two questions. We have one from Albert Ansah, the editor of Ghana News Agency. The question is, how is climate impacting on the occurrences of diseases in the region or sub-region, and what is being done to deal with it? That is the first question. The second one comes from Kat Lay of The Guardian, UK. The question is, can you tell me how much of the continental response plan for cholera is currently funded? Back to you, Prof.
Thank you. So on the side of the climate change, what is being done? It is true that with all the presentation, we can really see that climate change is a big driver, whether we are talking about cholera with the flooding, that is increasing the number of people exposed and the number of cases and therefore number of deaths, whether we are even talking about dengue, because those mosquitoes need to have the proper environment. And beyond those outbreaks, we can also talk about malaria and other vector-borne disease. So what is being done? It's being done at different levels. First of all, there was that climate change and health meeting that happened a few weeks ago in Addis, where the different scientists sat together and see how can we have a multi-sectorial approach, because we need to have a clear environment so that we can reduce the circulation of the different vectors, and later on being able to address it with the different medical countermeasures. So now on the other side, what we also do is to better understand the weather. So we have a tracker where the colleague from the surveillance every week assess the upcoming changing weather. So that's also an indicator that support the different countries to prevent. So now that we know that we expect some flooding in many of our countries, it's the time to ensure that we have the stockpiling, which we are currently doing, but also to ensure that we train the right people so that we can prevent the occurrence. We know that we'll have more cases of cholera coming, so therefore we need to have the vaccine ready, we need to have the IPC, we need to have the wash, which is also ready. And that's come to the question of Cathy. Out of the 241 million, 231 million, how much has been already mobilized? So during the UN General Assembly, Gavi has pledged to support all the 10 million doses of vaccine. That is around $48 million. And the exercise that we are doing this week with all the different partners is to actually to update the funding on the different activity. And that will bring what we call an incident action plan. So we know exactly what we do have at this stage and how we can use those resources for the country that we prioritize, DRC, Angola, Burundi, and so on. The activity will be around the WASH, around the IPC, and of course, around the surveillance.
Thank you, Prof. Let's take the next two questions. I have one here on measles, which appears to be worsening with 20 countries affected at the moment. What is driving the spread of this disease? And then the second question here is on the G20 summit. How can G20 members help African countries introduce innovative domestic financing mechanisms, such as taxes on unhealthy products, to generate dedicated funds for health initiatives? Those are the next two questions. Prof, if you got them, back to you.
Yes, thank you. For the first question on measles, there are quite a number of drivers of measles, but the first one, the most critical, is the low immunization coverage. This is the primary driver. So normally, the measles vaccination occur during the routine immunization. So we expect to have a threshold of 95% when we consider that we have what we call the herd immunity. But unfortunately, in place where the system is weak, you have the disruption because of the conflict, the other pandemic, the concurrent outbreak, it makes it very difficult for the country to reach the threshold that is expected. The second driver will be the population movement and displacement. And this makes always the link between the peace and health. We have countries like Sudan, even DRC and CAR, where the movement of population lead to pocket of unvaccinated individuals. That's one of the other driver. So altogether, if you have the population displacement, if you have the low immunization coverage, and of course, if you have a weak health system, that are all the drivers. Now you have all the order that we all know, the socio-economic and environmental factors. So that's what I can say that are leading or contributing to the gap on measles. Now the question that is raised, what the G20 can do for the financing. I start by mentioning, apologizing that that's actually the question that Dr. Kaseya is really bringing on the table. From the time we were at CEFIA, we came with the promise to say, okay, how can we support some of the key activity for the sovereignty, for the financing, ensuring that we have the domestic financing at the country level. We also have those blended financing. And in the blended financing with all those corporate, there are opportunities that the G20 can also bring, because we know that a number of the industry that are working in the continent are also having some grant or support coming from the G20 countries. So they can support in that way, but also they can support in moving toward the new public health order, where we want them to invest in health rather than the charity. So by understanding the new paradigm, by adhering to that, by also understanding and appreciating that at this stage, the Africa is leading the health transformation, but that we need the support from the multilateral organization. So that's also a message, a political message that the G20 can take and push at the level of all the businesses and partners to ensure that we are aligned on the way we move toward transforming the health in Africa.
Thank you, Prof. Let's cross back to the floor. We have Rachel Abuja from the Nigerian News Agency. Rachel, you have the floor.
Thank you so very much, Prof. Good afternoon. And congratulations on the successful conference, the public health conference. I read some of the stories and they went well. So my first question will be, with climate change driving outbreaks like cholera, dengue, and malaria, which you've spoke about, how can African countries better integrate weather forecasting, WASH, vaccines, and multi-sectoral planning to prevent future epidemic effectively? That's one, because I remember you saying something like this, of this nature, just last week, and it's still happening. We're still recording cases. Now, given the ongoing cholera outbreak in multiple African countries, what lessons from Burundi, low case fatality rates, can be applied to strengthen outbreak response and patient management across the continent? Prof, in your own word, can you help us describe the continent One Health approach mechanism as we celebrate or commemorate the AMR week for awareness in no time? Thank you.
Thank you, Rachel. Back to you, Prof.
Okay. Thank you so much, Rachel from Abuja. So on the first question of climate change, and the question is quite clear, looking at taking just the example of cholera, how can we bring together the weather forecasting, the WASH, the infrastructure, and all the other opportunity to respond? The best way that we know is to bring everyone together. Bring everyone together as we are doing within the IMST. Just to remember that the IMST, the Incident Management Support Team, is a platform. This is co-led by Africa CDC and WHO, bringing more than 28 partners together. The reason why is because then we can have the WASH expert bring on board. We also have the colleagues from the surveillance, both on the level of the detection, the epidemiology, the genomic, the weather forecasting, but also bring other partners. That one, bringing people together at the strategic level, which is the IMST. Now, the other layer really is to bring everyone together at the political level. And that's why we really push to have the launch of the Continental Plan and also the Continental Task Force that has to be at the presidential level, because then they will be able to bring all the different actors. The issue of climate in a country is not handled by the Ministry of Health, but by the Ministry of Environment in some countries. So by having the presidential task force, then all those different ministries will be talking together, the infrastructure, the water, environment, the Ministry of Health, and of course, the Ministry of Finance. So by bringing those people together, once again, at the strategic level within the IMST, at the political level, at the presidential and continental task force, that's one way to achieve that. But the last one, which is also the most critical, is at the operation level. How can we implement what we have in our plan to ensure that we actually use the data for the forecasting to have the proper stockpiling in countries where we know that the outbreak will be coming? So that is something that is moving. It's a transformation. It's a new paradigm on the way we respond to outbreak in the continent, and we believe that we'll keep on improving as we learn. And talking about the lesson learned, what can we learn from Burundi? MPOX, they have thousands of cases, they have one death. Now we move to cholera, they have around 2,000 of cases, they have I think 10 deaths so far, one of the lowest case fatality ratio. So what we are learning from it is that they really invest on isolation and case management. And this has had an impact not only on reducing the mortality, but also on reducing the spread of the disease. Because when people are isolated, then they are provided the medical support, the psychological support, but are also fed. So they don't need to go out, they don't need the family to bring the food and therefore to be contaminated. This is a lesson learned, a big one. However, not every country can implement it the way Burundi did. Sierra Leone, for example, they've managed. They were starting with the home-based care, and then they moved to the health facility care because they managed to decentralize the isolation and case management. This morning, we were talking with Liberia. It's a bit difficult at this point of time because the system is overstretched to really had all the patients in the health facility. But this is a movement, and they will receive some support from the World Food Program to ensure that all the patients are fed, so that we have the medical management, we have the psychosocial, but also the food that are provided. So the last question was on the One Health. Can you repeat, please? The One Health and antimicrobial resistance.
Thank you very much. For One Health, as we approach the Awareness Week for One Health, I would like you to describe the continent's One Health mechanism as of now. What do we have? Are we coming together? Is every agency involved working together? Do we still have lapses? I say this because in Nigeria, after our JE, you find out that some agencies or ministries are lacking behind. So that did not give Nigeria a good mark to say. So with that, I would like to know how other African countries are faring. Do they still have such lapses where you find environments not doing very well, and maybe agri is lacking behind, and it's just the health that is being recognized? Thank you, and over.
Okay, no, thank you. I think yes, Margaret.
Yeah, I was thinking let's get the next question and you can come in after that. So we have Gabriel Emmanuel from NPR. Gabriel, you have the floor.
Hi, thank you so much for doing this, as always. I had two questions. One is I wanted to understand more about how this outbreak of Rift Valley fever basically compares to in the past. Does this look different or unique in any way? And then also with the cholera, it's kind of an ancient disease, as you've mentioned, that we know how to deal with. And I'm wondering if its resurgence and this wave kind of is almost like a canary in the coal mine, or shows things that could be coming if it says anything bigger about our grasp on public health. Thank you very much.
Back to you, Prof.
Yes. So for the first question on the One Health, as you mentioned, there is a series of joint external evaluation that are happening in many countries. You mentioned that Nigeria a few weeks ago was Namibia, Madagascar, and others. And it's when we have all those results that we'll be able to really to have the picture of what we are seeing in the different states. But what we can say is that there's a lot of progress. There's a lot of progress because, you know, bringing different sectorial, different minister, the one in charge of health, the one in charge of environment, the one in charge of livestock, bringing together, speaking the same language, that has not been an easy part. You have countries like Cameroon and others who have managed to bring a One Health program. We're trying to bring the different actors together. So this is really an improvement that we see. But the most critical point is, how do we send the information in our communities? How are we making the connection with the way we are raising our animals, the antibiotic that we are giving to them? How we also change the narrative, saying that it's not because you prepare your chicken that you will kill the antibiotic. They will still be there and they will still move to the adult. How also are we encouraging the prescriptor to reduce on the drug that are being prescribed, and also to limit the auto-medication? And lastly, at the political level, how are we managing to convince our stakeholder that the antimicrobial resistance is the next pandemic? Because by the time we reach to 2050, millions of people are expected to die because of antimicrobial resistance. So it's really a continuum where we are bringing stakeholders together, but more importantly, how we are sending the information to all the different populations to address the issue of antimicrobial resistance. So on the question of bit of Rift Valley and cholera, saying that what is new, do we know how to handle? I start by saying that when I was highlighting the continental plan for cholera, this is a disease that is preventable. Cholera, we know. If we want to stop cholera, we need to provide clear water to our population. In case we have an outbreak, we know that we need to have adequate surveillance. We even have this innovation called CATI, where we integrate different part of the response. We can have the detection, we have the IPC to the wash. We also have, in some case, the antibiotic actually to take care of some of the severe patients. So we know the challenge that we really have talking about cholera or even Rift Valley fever is how do we mobilize the resources to ensure that we actually change the narrative. If you go in the eastern part of DSC, where you also have these outbreaks, you might have some tap water, but how confident we will be that the water that we have there or in Sudan or elsewhere are actually clean, potable, so that the population can drink? The challenge is that you may have the water available, so people have access to that water, but that water is not clear of the Vibrio that is causing cholera. So yes, we know what to do. Yes, those outbreaks are changing because of the number of cases, because of the number of deaths. Rift Valley has been present in many other countries, in Central African Republic and other. But we can see the number of cases, the way it's increasing. So to summarize, we need to be more coordinated, which we are trying to do. We need to mobilize more resources, going back to the issue of financing health, and then we can invest more on responding to those outbreaks, because we imagine if we did not have this cholera in country, $231 million could have been very useful on many other things. So now we are investing it in responding to those outbreaks. But as we move, reinforcing health system is the key to ensure that the money can actually move to universal health coverage or any other present needs.
Thank you, Prof. Let's take the next question. We have Agnes from New Vision in Uganda. Agnes, you have the floor. Agnes, can you hear us?
Yes, I can hear you loud and clear. Thank you, Prof. Yap, for the good presentation and bringing us to speed in regard to public health emergencies. Margaret, thank you for being a good moderator. Yes, my question is about Ebola. Yes, you said we have 27 days to end Ebola outbreak in DRC. Yes, you've done a very good job in regard to responding to this outbreak. People have been vaccinated, the sick have gotten treatment. But as a public health specialist, the question is always not to end with the treatment and care, the response. How are you empowering such countries that have been affected by Ebola and other outbreaks to help the survivors? For instance, when you look at the Ebola, it comes with a lot of health implication, economic implication, social. We see these people really get sick. Some of them, when they go back to the community, they are rejected by their wives, by their husbands, by the community itself. All their clothes, beddings are burnt when they are, discharging them. They don't go back with them. Even at home, they have to burn them. They've been in hospital for long. They've lost their jobs. Beyond the response and treatment, how are you supporting these survivors and their families beyond to go back and live meaningful life? Thank you.
Thank you, Agnes. Back to you, Prof.
Yes, thank you. Thank you so much, Agnes. This is a very good question and at the same time quite challenging, which once again remind us that health alone cannot solve all the issue. We need to have that multi-sectorial approach because now we are moving from health to the social welfare, how we take care of those people after they are out of the hospital. So many things. The first one that remain within our control is how do we engage the community. You remember last week I present the Guide du Communicateur, which is what is being used to actually engage the community while the outbreak is going on, but also after. The good thing with this specific outbreak is that we are in the countdown and we still have the colleagues who are in the community. So they keep on engaging the sensitization to ensure that the message is going through, but also after the discharge, you've seen in many social media how they were supported with the different actors, bringing back to their home, showing them to the community to highlight that now they are safe, they can go back. But the issue of now, how are we sustaining them after the outbreak has ended? This is the conversation that is happening between the Ministry of Health and others. Because yes, we have the social part, but we also have even the health side. As you know, the Ebola can remain in the sperm for quite a number of days, weeks, and even years. So which means that the surveillance should continue of those survivors because anytime a case can come out from that area. So to be very transparent, it's a work in progress. In some case in Guinea, in DSA in the past, there have been some cohort of survivor that has been supported financially, psychosocially by some partners. But for this specific outbreak, things are being put in place.
Thank you, Prof. And with that, we have come to the end of the briefing this week. I will hand over the floor back to you for your closing remarks.
Thank you so much, Margaret, and thank you once again to all the journalists for your presence, for your engagement, and more importantly, for all those questions, really always ensuring that, when we come here, we are well prepared because we know that we need to be transparent, we need to be accountable, we need to provide the right information. And then when we go back now, we share all those questions, all those feedback to our colleagues so that they know that one, they are supported, that two, they are accountable to you, to our community, and to our leaders. So I will end by thank you all our colleagues from different countries, from different organizations who are working tirelessly dealing with cholera, Ebola, measles, Rift Valley fever, and all those diseases. So this is really a big thank for them and big thanks to you. And I wish you all a very nice afternoon. Thank you.